I would like to welcome you to the OVA Circle once again for yet another exciting episode with Dr. Amanda Kenya. This episode is proudly sponsored by Verushka Wigs. My name is Veronica, and I'm the founder of the OVA Circle, a platform that educates and empowers women navigating perimenopause and menopause and beyond. Welcome, Dr. Amanda Kenya. It's nice to have you again.
Thank you. Thanks for having me back. I'm Dr. Kenya. I'm an obstetrician and gynecologist with a special interest in menopause.
Right. So in our last episode, we discussed, it was like Menopause 101. Yeah. We talked about menopause, what is perimenopause, and what is postmenopause.
Yeah.
And about the symptoms and how to naturally navigate menopause and perimenopause, right?
Yeah.
I find that word so wordy, perimenopause, like it's a lot.
Yes, it is.
Anyway, so in this episode, I would like us to touch on hormone replacement therapy, which is now known as menopause hormone therapy. Yeah.
Right.
So first of all, why the name change, or where do we start? Do we start with what MHT is, or
actually, you can do both at the same time.
Okay, tell us.
We still have HRT, and then there's MHT. Okay, so the difference is hormone replacement therapy is given to women whose ovarian function has failed too soon, and now we want to get their hormones to a place that is normal for someone their age. So I'm replacing your hormones. I want them to be the same as someone who is your age. So maybe you're 35 years old. I had to remove your ovaries and I don't want you to go into menopause. So I'm going to give you hormones to replace what you're not getting so that your hormones are the same as what would be a normal 35-year-old.
Okay, so
right?
that's
hormone replacement
therapy. Yes.
Menopause hormone therapy is whereby you've gone into menopause or you're in the perimenopausal stage and your ovaries are not producing as much as before. And I don't want to replace. I don't want to give you hormones so that you are like someone who is 30.
Okay.
I'm simply giving you a bit of hormones to help with your symptoms.
Right.
Yeah, that's the difference.
Oh, yeah. Wow. That is so enlightening. I had no idea.
Yeah.
Thank you. So HRT is to replace, is for younger patients, you'd say, or people who had sudden menopause or something like
early
that.
menopause.
Yeah, so you're replacing to match what they would have had.
Yes.
But for MHT, it's to give a little bit to manage symptoms.
Exactly.
So is that the main use of MHT? Yeah,
yes.
Is it mainly for symptom management?
It is. It is. So menopause hormone therapy is the first line treatment for moderate to severe vasomotor symptoms. That's hot flashes, night sweats, cold flashes, severe or moderate genitourinary syndrome of menopause, which is vaginal dryness, painful intercourse, recurrent UTIs, also for severe mood disturbances and bone loss, okay? If you're postmenopausal or perimenopausal and your bones, maybe due to your family history or something else, are losing their density a bit faster than we like, we can protect you with estrogen. So those are actually the indications for menopause hormone therapy. Even though we found that in women who receive this hormone therapy, there are other benefits, right? But the main reason we're giving you hormones is to help with your symptoms.
Okay, so the main users for prescribing MHT to a woman in perimenopause or who's menopausal, you mentioned is to prevent osteoporosis, bone loss, for hot flashes, is vasomotor symptoms, and you mentioned
vaginal and genital symptoms.
What kind of vaginal or genital symptoms?
Recurrent UTIs, vaginal dryness, and painful intercourse. That is moderate to severe. And then we also have, as an aside, which is still part of MHT, testosterone, which is given specifically to women who have a low libido. That is not just a low libido, but is negatively impacting their lives.
Okay.
Right?
Okay. Let me take you back a bit. Okay. So what hormones are given in MHT?
Right.
You mentioned testosterone. So I'm like, hold on.
Yeah, okay.
Let's go back. Yeah.
Rewind.
Yes, yeah.
So the types of hormones we give is estrogen.
Okay.
Right? Because we're losing estrogen. And then we might give you progesterone if you still have a uterus. Okay. So some women had their uteruses removed.
Right.
And so you wouldn't need progesterone. But if you have your uterus, we're giving you progesterone to protect the lining of your uterus from becoming too thick, because that's what estrogen does to it. And if it gets too thick and it stays too thick for long, it can turn into cancer of the lining of the uterus. That's called endometrial cancer. So progesterone prevents that. Okay. So there's estrogen only, or there's estrogen plus progesterone. In some cases, we can give progesterone alone, which is really good for sleep and relaxing and insomnia. It also helps with the hot flashes a little bit, though not as effectively as if we combine it with estrogen.
Combine the two.
And then there's testosterone for the low libido. And then there's specifically vaginal estrogen, which can be given alone, simply for the vaginal dryness and all the symptoms down there.
Okay, so is the vaginal, okay, so what is the mode of administering these drugs?
Right.
Yeah.
Okay, so if we're giving estrogen alone, we can give it in form of a pill, in form of a gel or a patch or a spray.
So estrogen, pill, gel, patch, spray. Okay.
Or even a ring that's put inside the vagina, a vaginal ring.
Okay.
And which method we use is going to depend on your risk factors. For example, some formulations are known to have a lower risk for getting a blood clot. And so we would give you a specific formulation if you have a personal history of having breast cancer or a blood clot in the past. Maybe you have obesity, and we know that it's safer to give you something through the skin instead of giving you a pill. So we'll give you maybe a gel or a patch. So the formulation we choose is going to depend on different things. But that's for estrogen. Progesterone is the same. It can be given in form of a pill, or it can be combined in a patch with estrogen, or it can be given as an insert into the vagina. And then we have testosterone, which is a gel. And then we have vaginal estrogen, which can be a tablet you put in your vagina, or a ring, or a gel, which you put in your vagina.
Okay, so let me just say it in the way I understand, right?
Yeah.
So you've basically said the mode of administering varies
hormones
from patient to patient, depending on their history. Yeah. So that's
and their preference as well.
And their preference. So that is what you determine in a consultation, right?
Yeah.
Okay. Yeah. So it's not one size fits all.
It's definitely not one size fits all.
Okay. Well, even is that the same for the dosage? Does the dosage vary as well?
Yes, we tend to start low and slow, right? So we would generally start with a low dose or a standard dose. And then depending on how you react and how your symptoms, the symptom burden, if it improves or not, we might increase the dose as time goes by. But usually there's like a lower standard dose that we start with and take it from there.
Okay, so you start low and you can iterate from time to time. Yeah. Okay, so if you've prescribed me with MHT, in how long should I monitor and then come back to you if I'm not getting relief? Do I wait for a month or 3 months? Yeah.
Okay, so it depends on the doctor who's seeing you, right? I like to be in constant communication with my patients. So you know, even a week after, if you want to talk to me and you feel like it's not working or something, we can still talk. But generally speaking, we give it 3 months, right? Before we start thinking about increasing the dose. 3 months for review to come in and talk about how you're feeling, if anything has changed. Hopefully you're still keeping your symptom tracker that we were talking about, so you can actually objectively see if things are getting better.
Okay, yes.
And then we can take it from there. So 3 months.
Okay. Yeah. I love that we're having this conversation because in this age of social media, there's a lot of information that is out there, and it's really difficult for us women or patients to filter and know what is good advice or what is not good advice, what is advice that sticks to the guidelines and what goes against the guidelines. So it's really, really confusing for us. And sometimes we feel like there's a tug of war between some specialists, because some are for hormone therapy, others are against hormone therapy. So it's actually a very conflicted position from where a patient stands.
I can imagine.
And that's really the reason behind the OVA Circle, to give balanced and accurate information.
Yeah.
But so it's always good to know what the guidelines are. So if a woman wants to know where to find correct and accurate guidelines, where would somebody start? Because if you just Google hormone therapy on the internet, you get so many hits. Like, what are some good resources that I would go to online?
Yeah. Okay, so I'm going to mention some, but then we're also going to leave some links in the description box, right?
Okay, great.
So a good place to start is a society, so a menopause society. There are several in the world. You can go on the website of the Australian Menopause Society.
I like that one.
Canadian Menopause Society. The Menopause Society and International Menopause Society.
Okay.
So you can go on the websites. They have lots of patient education. They're, explaining things in very simple terms that everyone can understand, not just doctors.
Right.
There are articles, if you prefer, there are videos, and it's a wealth of information out there. And you can even see the guidelines and decide for yourself if hormones are something you want to try.
So you'll share those resources with us. Yeah. So you recommend the official menopause societies. Yeah. So we'll have that in the description box. Yeah. I'm using my phone because this is a very medical discussion, and I need to always refer to my phone. All right. So okay. So let me go back to what I was saying, social media again. Right. Yeah. I've seen these terms used, bioidentical and synthetic hormones. Yeah. And then I've seen people argue bioidentical is just a marketing term. So again, I'm confused. I'm like, what's the difference between bioidentical and synthetic hormones? Okay. Yeah.
So the way we make hormones has advanced from the way we used to make them, right? So even many of the studies that were done in the past on hormone treatment were done using hormones that we currently don't really use that much. So as medicine is advancing and technology is advancing, we have been able to make hormones which are becoming more and more similar to the hormones that our ovaries are producing.
Okay.
So bioidentical means it's almost like a perfect picture of the hormones that your ovaries are producing.
Right.
And synthetic means it's a bit different, though it kind of does the same thing. Right? So it's not a marketing gimmick. Bioidentical hormones are preferable because they're found to have a better safety profile in terms of putting you at risk for breast cancer and putting you at risk for a stroke or a blood clot. What is a marketing gimmick is what we call compounded bioidentical hormones. That's where a pharmacy is making some kind of special formulation of hormones and charging you a lot for it. We don't have much of that in our market yet. I'm sure it'll come with time. Because we know how pharma is. But for us, we do have bioidentical hormones in the market. We do have synthetic hormones. And more we're preferring to go towards the bioidentical ones.
Okay.
Yeah.
And right now, because we're in Kenya, so are these hormones available here? Like if a woman needs hormonal therapy, what's the availability like? What's the price like? And is it covered by insurance?
Great question. I feel, first of all, if you have been prescribed hormone therapy, which it should be prescribed, it shouldn't be something you're getting on your own.
Yeah.
It's upon the person who has prescribed it to you to let you know where to find it, right? Imagine me giving you a prescription and then leaving you to your own devices to fend for yourself and look all over the place. So there are specific people and pharmacies that provide these drugs, these hormones, but you have to know where to look. And we have looked up and down and we found a couple that we use and who are who always keep them in stock. So
supply would not be an issue?
Would not be an issue if you really know where to look. But still, they need to be available in pharmacies, like in most pharmacies. This is not, if you needed an antibiotic like Augmentin, you wouldn't have to look so far and wide. So why are hormones just not available?
Yes,
and then when they're not available and only specific people have them, they tend to be more expensive, right? So maybe like for a month's dose of estrogen gel.
This is estrogen only?
Yeah. Because we can give them separate but together. So like estrogen gel would be like maybe 5,500 for a month.
for a month of estrogen only. And so
then
if you're combining it with progesterone,
so maybe you need progesterone, which is like 3K. So that's like
8,000, almost 9,000 shillings.
If you're using a patch, it's more like maybe 10 or 12K per month.
So also the price varies depending on the
with the formulation as well.
Okay, so we'd say give and take about approximately 10,000 would be a woman's budget. And is this covered by insurance?
No, it's not.
You were going to say, of course not.
Of course not. There are some international insurances and some places of work that actually provide that they have their internal kind of insurance policies for their women, which is great, that can cover. But for the vast majority, these are not covered by insurance.
It's great that we're having this conversation because these are drugs that should be covered by insurance, because in our last episode you mentioned that a woman will spend a third of her life in menopause. And this is also an age when women are at the peak of their careers.
Exactly.
And I feel companies and corporates in conjunction with insurance companies should really look at this, because you do want to retain your good skill, your expertise in your company as well.
You want to keep being able to work.
I love that we're having this conversation and that you've actually brought this to light. Okay, so more. Let's go back to the hormones. Let's talk about the risks. And I don't know if we can go back to the fear around hormone therapy, because ever since, was it the Women's Health Initiative, when they said hormones, HRT causes breast cancer. Now a lot of us are having difficulty unlearning that. And that's the only risk we know. And then, but we're okay taking the birth control pill. We're okay drinking alcohol and any other medication. But now when it comes to HRT is where we draw the line.
Not.
And I'd like us to use this education to re-educate and change people's perception on hormonal therapy. And how it can also improve your quality of life. If your menopausal symptoms are really affecting the quality of your life, you really don't need to suffer as a woman.
Exactly.
So I want you to talk about
the fear,
where it started and where we are now. You can touch on Women's Health Initiative a bit and where we are today.
Okay. So the Women's Health Initiative was a huge study, still up to date. It's the biggest study on menopause that's ever been done. And they wanted to find out the cardiovascular risk of taking hormones. So that's the risk on your heart. So they gave women hormones, and some they didn't give. And those who they gave hormones, some they gave estrogen only, some they gave estrogen with progesterone, and they also gave them different kinds of estrogen. So they were trying to see sort of everything at a glance. What impact do hormones have on women's health? Even before the study was completed, they stopped the study after having some findings, and they published, even before they published, they just went on the news and said, hormones cause breast cancer. Okay. And we're stopping the study because it's too risky. This was huge. It was on the news. It was in newspapers. Doctors stopped prescribing it. Women were throwing their pills down the toilet. It was really dramatic because of that information. But a short while later, even the people who did the study, and if you actually look at the study now, you'll find that the hormones actually did not increase the risk of breast cancer. And many studies that have been done since with newer research methods and more advanced research methods have found that the increased risk of breast cancer from taking hormones is much lower than we thought. And in fact, the risk is higher if you take a glass of wine every night. The risk of smoking, right? So the risk of developing breast cancer and cardiovascular disease and stroke is much, much less than we thought. And now we have ways of, if you have a personal family history or a personal history of these conditions, we have ways of going around it to provide you with hormones in a way that is safe for you specifically. So it's individualized.
But this new research did not make it to the news.
Of course not.
Yeah, yes, right.
Of course
right,
not. We only like to put bad news on the news, and then the good stuff that people really need to hear about is not as publicized.
And that, so what I'm hearing is the Women's Health Initiative study was flawed in how it was done, and the statistics were not as ginormous as they made it out to be.
Also the population they were giving hormones to were women who are much older than we typically give hormones now.
Oh, really?
Right? So the women were like 60s, 70s.
Already.
And now we know we're giving hormones earlier, right? Because it's safer within the first 10 years of developing symptoms.
Okay.
And especially if you're less than 60 years old.
Okay. All right. Okay. Oh, thanks for clearing that up. Because that's something we really need to unlearn. There's that fear keeps lingering. I don't know. I don't even know where I got that. Like, okay, hormones cause breast cancer. Yeah.
You must have had it somewhere and it just stuck.
But through my own research and my reading and looking at the guidelines from the society that you mentioned, like hormonal therapy is recommended, especially for women with severe hot flashes or who have a family risk of getting osteoporosis. And I think that's also important to acknowledge, that it could be beneficial for some women. So
so we're trying to unlearn all this and, keep up to date with the current guidelines.
Right. So have you been faced, so in your practice, I'm sure you evaluate each patient before prescribing hormones and to evaluate their risk. What would put me at a high risk and where you'd say, I'm sorry, you cannot.
It's not advisable,
to give you hormones, use natural ways or use medication.
So that's a good question. So what you're referring to are contraindications. A contraindication is something medically that would prevent me from giving you a certain treatment. So there are absolute contraindications, which means if you have this one thing, there's absolutely no chance I'm giving you hormones. And then there are relative contraindications whereby if you have this thing, I can work my way around it. So the absolute contraindications are if you currently have breast cancer that is responsive to estrogen. If you currently have a blood clot somewhere in your body, if you had a recent blood clot, if you currently have uncontrolled high blood pressure, it has to be uncontrolled. If you currently have severe liver disease, because estrogen
is that like cirrhosis?
Yeah, like liver cirrhosis or a type of liver cancer. Right? Those are the main contraindications. The absolute ones, right? I think there's one more I'm forgetting. But then the relative ones are, for example, if you are obese, right? We know that if you're obese, giving hormones can increase your risk of getting a blood clot. So I'm going to give you maybe a transdermal formulation. That means going through the skin instead of giving you a pill. Because the pill gives you a higher risk. Right? Say if you have a cardiovascular disease, so maybe you have a heart problem. I'm going to give you hormones again through the skin rather than a pill because it's been shown to be safer. So those are some of the relative contraindications that we can work around. We can change the formulation or we can make sure we're giving you a bioidentical instead of synthetic. So you find for the vast majority of women, hormones are safe.
What about if I have a family history of breast cancer? How would you navigate that? I'm struggling with my symptoms, like it's affecting the quality of my life.
So having a family history of breast cancer is not a contraindication to hormone therapy. A personal history, however, like you have had breast cancer before, then we would want to give you maybe the vaginal estrogen if you need estrogen, or we can give you other combinations of hormones to help with your symptoms, especially if that breast cancer was responsive to estrogen. Because there are different kinds of breast cancer. There are those that respond to estrogen and those that don't. So if it was responding to estrogen, we definitely want to, in conjunction with a breast specialist decide if the benefits for you outweigh the risks.
Yeah? Okay.
And you know that might be different for many people.
Right.
But a family history is not something that we generally strongly consider when thinking about hormones.
Speaking of family history, this has not come up in our last episode, but we were discussing it earlier about your menopausal symptoms, whether if you have a sibling or your mom, whether you would share, would you have similar symptoms? Is that something that has been proven, or would you both reach menopause around the same time?
Yeah, the one for reaching menopause around the same time is actually a fact. It's documented. So around the age that your mom or auntie or elder sister went into menopause is probably going to be the same for you, unless you're doing something extra to get there faster, like smoking or excessive drinking, or maybe you have an autoimmune disease. Maybe you had your ovaries or your uterus removed. A lot of people don't know that having your uterus removed, even though you still have your ovaries, can bring menopause a bit closer, like 4 years closer, right?
Okay.
As for whether or not you'll have the same symptoms as your mom or your aunties, in terms of symptoms, it's not so clear if it's going to be the same. But for the age, it's more clear.
Definite. Yeah. Oh, that's great. So that also brings me to the point of why it's important to have these conversations, especially in our communities, in our families. Because I don't know if have you noticed there's a lot of secrecy or shame, or not enough women are talking about it. But when you share your experiences and talk about it, even with your mom or your sister, you kind of feel like, I don't know, comforted in a way. Yeah,
that's why the OVA Circle is so needed. That community is so impactful.
It's so impactful, even for me. Yeah. And then speaking of, I know you touched on data, and I mean, so I'd like to also talk about the data around the current data, like in Kenya, because I was looking for data online, and I realized the last numbers and statistics that we have are like from 2014, and it doesn't even really cover all of Kenya. And which I find bizarre. Because is it that after we have data on pregnancy, on child mortality, on puberty, but when it comes to menopause, nothing, like crickets. Like,
no one cares.
I mean, how do you feel about that? Because I actually get a bit triggered, because is it that we are only valuable for as long as we are reproductive, and then thereafter we don't need to carry out data? Because this data is really important, because for us as Kenyans and Africans, it helps us tell our story, our experiences, and we control the narrative,
of what's
because
going on.
We don't have data about like the Kenyan or the African experience, and that's why I'm so passionate about the OVA Circle. I don't know if it's that's your experience as well in terms of data, because
it definitely
there's hardly anything.
There's hardly any data. And you're right, it's so important, not just for us to control our own narrative, but even because we're basically doing things based on research that has been done elsewhere.
Oh, can I give you a high five? Yeah. Oh my God, yes. No, because that's true. Because that's been really my bone of contention. We just receive instead of us documenting our symptoms, how we experience menopause as Black people, as African people.
Even something as simple as the average age of menopause, which we know in the books is 51, 52. For us, it's a bit earlier, we found. And there's a study that was done in Western Kenya. They found for us, it's around 48. And then for Asians, it's even earlier, like 41, 42. So around the world, things are different, and we need to have our own research, our own data. We need funding for menopause studies so that we can figure out ways that are to tailor things to our population, how it looks for us.
How it looks for us.
Exactly. For example, one of the major symptoms that African women report is joint pains. But joint pains are not an indication for menopause hormone treatment. That's because other people around the world don't have these symptoms as severely as we do. So maybe if we had our own studies and our own research, we could have guidelines that fit us. Right?
Exactly. So I'm so passionate and so grateful for this space.
That.
So I think it's just about getting the word out there. And it has to start somewhere, right?
Yeah.
Okay, let's go back to HRT. We got a bit sidetracked. Okay, we've touched on the different formulations. There's estrogen only, estrogen, progesterone, and also testosterone. Yeah.
And vaginal estrogen.
And vaginal estrogen. Yeah. And when is vaginal estrogen given? When is it mostly for vaginal dryness, or?
Yeah, it's given for vaginal dryness and pain during intercourse and just discomfort in the vulval region.
Is it a gel? Oh, you said
a
gel or pill?
Or it can be a pill, or even a ring.
I've never heard of vaginal estrogen. Yeah. I'm like, wow.
Actually, I recommend vaginal estrogen to anyone from 40 years and above. Yeah. Whether or not you have any other symptoms. So here's the thing, if you were to use vaginal estrogen in the way that it's prescribed for a whole year, that's the equivalent of taking one estrogen pill.
Really? And is it localized, or?
It's acting locally.
It's not
locally.
Getting
into your bloodstream and doing all sorts of things. It's just acting locally, keeping your vaginal tissues nice and plump and juicy, preventing that dryness and thinning of your tissues. And remember, we mentioned in the last episode that some women experience very severe, we used to call it atrophy, which is wasting away. We don't use that word anymore. It's a bit offensive.
But you said the labia can disappear.
Your labia minora, your small lips can literally be reabsorbed, right?
Yeah.
Because estrogen is keeping these tissues there nice and plump, and replacing it is so easy, and also preventing these recurrent UTIs, which can be really severe in older women and can cause sepsis, which is an infection everywhere, and can even kill.
So vaginal estrogen really is beneficial for such cases, yeah?
Yeah.
Okay, all right. So about when to start HRT, or let's say, MHT, about when, how would I know when I should start? Is it symptom-based? If I feel like I'm really struggling, is that something the doctor determines, or is it
it's something we determine together? Okay, so what we do in medicine these days, or in all aspects of medicine, is shared decision making, right? You're not coming to the clinic and I'm telling you what I'm going to do and what I'm going to give you. We're going to talk about it and figure it out together. But in terms of when you should go and see a doctor, is as soon as you feel like you want to.
It's too much.
If you feel like you're not coping, maybe at first you thought these symptoms were mild. You're not sure, is this mild? Is this moderate? Are my symptoms severe? I'm actually not sure. Let me go talk to a doctor about it, and we'll figure out together if these symptoms are severe or not. So I found in my practice, most of the women who come to me have severe symptoms because they have waited. They've tried everything. I'm really not seeing many people with mild symptoms because they're just simply not coming because they might not need to.
All right. And is MHT something, okay, if I came to you, is it something that I have symptoms that I'm struggling with. I can cope, but I'm struggling with it. It's, that's how, you always negotiate with yourself.
Yeah.
And then I come to you and I'm really not sure. I still want to take MHT. Is it something I can try and then decide, no, I'm going to stop? Is it, or do I have to stick on it for a period of time?
You can stop anytime you want.
So I can try, and I feel, are there some women who do not benefit from MHT?
There are women who tend to need higher doses. And we find that mostly in the perimenopause period, before you lose your period completely, before menopause, symptoms can be quite severe. So like I said, we start on a low dose, maybe after a couple of months, we might need to increase until you're at the highest dose. And it's very, very uncommon to have someone not benefit from hormones and not have their symptoms improved once you've taken them at an appropriate dose.
Oh, this is a random I heard. It's not, I can't really say for a fact. I've heard some women say, I tried hormones or I took MHT and my symptoms were horrific. Like MHT gave me panic attacks or crazy thoughts, and I've heard. So is there a possibility that some women just may not react well with MHT.
Yeah. Although it's not common.
It's not common.
Like with any other drug, someone might not just gel well with that.
Okay,
So maybe it was the specific. So we don't give up, right? If we felt like your symptoms were severe enough to warrant hormones and you're not having a great reaction, maybe we might try a different drug. We might try a different kind of estrogen or a different kind of progesterone. Try and find something that works for you. And if it's just not working at all, then we can stop and just think about other non-hormonal treatments.
Like lifestyle modification,
and the supplements.
Okay. And how long is a woman required to stay on HRT?
Yeah.
So MHT.
MHT.
Yeah.
So a woman can take MHT for as long as the benefits outweigh the risks. Okay.
Or even past 60, even into postmenopausal 70 years. Yeah.
However, we found that the best safety profile is within the first 5 years of taking MHT, especially if you're under the age of 60.
Okay. Within the first 5 years, just repeat
10
that?
years. So within the first 10 years. And if you don't know when you went into menopause, then we use the 60 years old.
Oh, so if I went into menopause at 50, between 50 and 60 is the safe. Is what is the safety profile for safest profile for starting.
Once you start in that window, we call it the window of opportunity. Then it's quite easy to continue longer, as long as there's nothing new that has come up that has put you at an increased risk of any of like the breast cancer or the clots or whatever. Now, when it comes to starting hormones, we generally don't want to start if you're above the age of 60, unless your symptoms are quite severe and we feel like there's nothing else that can help you.
Even if you're not, what if you're above the age of 60 and you're not yet in menopause?
If you're above the age of 60 and you're not yet in menopause, first of all, congratulations.
That's not common, right?
It's not common at all.
Okay. All right. But it doesn't happen at all?
I mean, I think I've seen a couple of women.
Okay. All right. Okay. What
we're talking about how long you can take hormones for. So now women, the studies have shown that women can safely take hormones for as long as they need to, as long as the benefits outweigh the risks, as long as you're getting your yearly checks and we're making sure everything is in order. So we're not just blindly taking hormones forever, but it needs to be under guidance of a qualified GYN.
All right. If I'm on hormone treatment, what tests should I be aware of that I know I must do? Is it annually? That the checks that I must do annually, because especially because I'm on hormone treatment, are there some tests that are that you highlight to your patients that you have to keep this updated?
So when it comes to this, it's more individualized and personalized based on how you started, right? And any other issues you might have. One thing I generally like to do yearly is a pelvic scan. If you have a uterus, I want to keep looking at the lining of your uterus and making sure it's staying nice and thin. It's good to keep checking your lipid, your cholesterol level. Estrogen can increase your cholesterol or it can help it go down if it was high. It depends on the person. So we see how you started and the baseline tests we did before you started the therapy. And then we're going to check yearly to see if there are any changes. We're going to look at your liver. We're going to take the opportunity. So what I like to do is now, when you're coming for your yearly checks, we're going to do a general check also. There's no need to go anywhere else. So the diabetes screening, we're going to check your BMI. We're going to talk about your nutrition and your physical exercise. Just a good checkup. Once you get to the age of 55 and above, maybe every 2 years, we're going to do a bone DEXA scan. That's a scan that looks at the density of your bones to assess your risk for a fracture, especially if you have a strong history or if your first scan showed that there was a problem. We want to see if your bones are getting better. We want to do mammograms once a year. Yeah, so those are some of the tests.
Okay, all right, okay. Okay, let's talk about some of the myths.
Right.
Yeah. Like MHT, I'll put stroke HRT myths because a lot of us still use the older term HRT myths. I've heard some say that it prevents aging. What do you think?
Okay. So No, it doesn't. Like,
like your skin will stay supple and wrinkle free.
Well, it can help with that.
Yeah.
But that's not why we're giving it, right? Aging is a natural process that we're all wanting to go through nicely and gracefully and without much turmoil. But you are going to age, you're aging. MHT is to help you with the symptoms of menopause. However, it does have benefits. Maybe I haven't mentioned the benefits yet.
The benefits of
MHT, other than helping with your symptoms.
Yes. What are the other extra benefits? Yeah.
It protects your brain and your cognitive function. So it prevents the decline into Alzheimer's, reduces the risk, of which women are at a higher risk than men.
Is this a conclusive and proven benefit, or
it is? It's a benefit, but it's not a reason we give MHT yet.
Oh, it's not a reason.
Yeah,
it's not a reason according to the guidelines we have. Yeah. Okay. But more studies are being done.
Yeah, and there's still lots of studies coming up.
This sphere is now. Research is ongoing
it's
now.
Happening
it's
now,
happening.
Thankfully.
So medicine is not black and white. Yeah. Things change. So
people's individual needs are different.
Yes.
So it also protects your bones. That one we know, right? Especially if you have a high risk of osteoporosis, or if you already have osteoporosis, which is loss of bone density. We're giving it to you to sort of improve that, right?
And that is in the guidelines. I think you've mentioned that. Yeah.
And then it does prevent diabetes. It reduces the risk of diabetes. It reduces the risk of obesity. It reduces the risk of depression and anxiety. Those are some of the other benefits.
These are the benefits that are outside of the guidelines.
Symptoms,
So if a woman is having like depressive symptoms because of they're hormone related, of course she doesn't know. Hormone therapy can help.
Yes, absolutely.
As opposed to nothing wrong with taking antidepressants.
There's nothing wrong with taking antidepressants.
But I'm just saying that hormonal therapy can help manage the depressive symptoms as opposed to antidepressants.
Right. So the specific depression that's caused by low estrogen is managed better with estrogen than with antidepressants.
That's how I was trying to say it. Yes.
But we found in some women combining the two may help.
Okay. Right. So this feels like it's a very personalized journey, because every woman's needs, family history, risk profile, it sounds like it's so different. So it varies from woman to woman. So it's really is. You need to find a doctor that you can work with, first of all. So it sounds like it's a long-term partnership as well. So I just want to highlight that it's a very personalized and individual journey.
So what your friend is doing might not apply to you, right? Or something you had.
Are there, is it possible to go through the menopause transition and beyond without taking HRT and still live a healthy,
absolutely
strong life?
Yes, absolutely.
For women who choose not to.
Absolutely. I think also now with a lot of awareness that's going on about hormone therapy, there's also a bit of a misconception that it is
it's what you need. It's what we all need. If you don't need it, you'll get dementia. Honestly, that's how I've been feeling. If I don't take hormones, I'm going to get dementia and heart disease.
That's not true. That's not a documented fact yet. It's social media. It is definitely, we need to find a balance between promoting the use of it, because it is needed for so many women, but not everyone needs it. And we don't have enough study to say that every woman who is undergoing menopause absolutely needs hormones. So that finding that balance is so necessary.
That gives me so much comfort that you said that, because I go on social media, I'm like, okay, I'm gonna get Alzheimer's if I don't use hormones now. And then it's really, really so difficult for us patients, I'll call us patients, to really know what do we do? And thanks for highlighting that.
Don't feel like you're missing out, right?
Like it's for women who feel that their quality of life is really big, and that there are some who really benefit from hormone therapy. Let's not also discount that.
Many do.
I want us to highlight that as well. Okay. Is there anything we may have forgotten about? I think I wanted this to be very simple, because it can get complicated. But
I think we've kept it simple.
You've kept it simple. I've been able to understand. I hope our listeners and anyone watching us can easily understand how we've discussed hormone therapy, who needs it, who should absolutely not have it. You highlighted that.
Yeah.
And I think I think that's it. Yeah.
Maybe something I haven't really touched on enough is low libido in women undergoing perimenopause and menopause. It's one of the symptoms which a patient wouldn't mention to me unless I ask. Right? I don't know if it's embarrassment or you just don't think it's a thing or you think it's normal.
But women deserve to enjoy sex. Yeah, that's you see, it's about
their whole life.
Throughout their whole life.
Yeah.
Yes, yeah.
So if you feel like you're low libido, so first of all, some people have low libido and it doesn't affect them negatively and they're completely okay with that. That's fine. You might not need anything. But if your low libido is affecting you negatively and affecting your confidence and your quality of life, then we give it a special name. That's hypoactive sexual desire disorder. So that means it is actually now a condition, right? That you might be able to get help for. And one of the ways of treating that is giving you a bit of testosterone. Just to bring that back. And women have found that it's completely transformed their lives. You know, a lot of women, that's their main complaint in the perimenopausal period. I was talking to a friend earlier and she was like, why would a woman need to work on low libido at 50? Well, women that still want to have full sexual lives.
Live a full life
throughout.
And enjoy. Yes, exactly.
Yeah, it's not just men. Yeah.
But speaking of testosterone, I think a lot of people think testosterone is just a male hormone for men.
Right.
I think maybe you need to, because you mentioned testosterone, we need to, I think I want you to highlight that women also do have.
Yeah. So believe it or not, in every woman, testosterone is actually the most bioactive hormone.
Exactly.
Right? You actually have more testosterone than any other hormone that's doing something.
But by bioactive, could you just simplify that?
Like it's actually working in your body. It's doing stuff, right?
Okay.
Like it's active. It's needed. Yeah, we have receptors for testosterone. It's not just a male hormone, right? Even men have estrogen, right? So
is that why during ovulation, some women are more sexually aroused? Is that when testosterone
libido,
like peaks or spikes?
Yeah.
So it is that hormone is
it's there and it's doing
women.
stuff.
Yeah, right. Yeah.
And so obviously when you have too much or too little, there's going to be a difference in how you feel and in how you act, but especially so when it comes to libido.
Right.
And so just replacing a little bit of testosterone is going to give you that boost that you need. Yeah.
Is it available in Kenya?
It is.
Yeah.
But the problem is, not just in Kenya, but around the world, I think only Australia have a formulation that's made for women specifically. The rest of us have to deal with the formulations that were made for men.
It
comes in a sachet. It's a gel in a sachet, right? So for a man, for him to get a dose, he would open the sachet and apply the whole of it somewhere and rub it in and wait for it to dry.
For men who are on testosterone
for whatever
therapy.
reason.
Okay.
Now for women, that is too much, right? So we need a 1/10 of that.
So you need to like eyeball it.
You need to eyeball it and for a couple of months until you figure out what exactly a 1/10 is. You need to make sure that a sachet lasts for 10 days.
This is why women's health needs more attention.
Right?
Because of, I mean, this may seem like a small thing, but it's not.
It's not small, right? So you have to figure out, okay, what is a pea size?
How much is a 10th?
We recommend a pea-sized amount. Like what is a pea size?
And it's open. You have to use a peg to
you have to close it. Or
right.
you pour all of it in a tiny container and close it and then just make sure by 10 days it's over. You know,
it's such a challenge. Yeah. So do women so if you prescribe testosterone, is it for the whole entire cycle?
Yes, it's every day.
Oh, okay.
A tiny amount every day.
All right.
And then with testosterone specifically, because for the other hormones that we're talking about, estrogen and progesterone, when I give you those hormones to make your symptoms better, I'm not going to keep checking your hormone levels.
So when you prescribe progesterone and estrogen, is it cycled or it's every day? MHT, is it cycled or it also depends on the individual?
It depends on your age and whether or not you're still getting periods. So everyone is going to get estrogen daily. Right?
Okay.
But whether or not how I give the progesterone is going to depend on whether or not I want you to have periods every month. So like a postmenopausal woman, at 55 is not going to be wanting to have periods. So she's going to take the estrogen and the progesterone continuously every single day.
Okay.
A woman who is like 45, 46, 42, like you started experiencing some symptoms in your 40s, you still want to get periods. Well, some do. And so I'm going to give you estrogen, but the progesterone I'll give you for half of your cycle. So I'll give you for 2 weeks out of every month, so that you can
cycle
have a bleed.
the progesterone.
Yeah.
Okay.
Yeah.
So it really is like patient to patient.
It is.
It's a doctor patient. It's not one size fits all.
Yeah.
And that's what I think we need to also stress. Yeah. Wow. Okay. I'm taking it all in. It's a lot, but you've really explained it in simple terms.
I'm glad.
Thank you so much.
You're welcome.
For coming back to the OVA Circle and for also being a part of our community as the doctor who handles medical questions. Thank you so much.
It's been really fun.
What I'd like to just encourage everyone is let's keep the conversation going.
Yeah.
There's no shame around speaking about aging, menopause. It's something that we should pride ourselves in, and it's also a blessing.
It is.
So thank you so much. And anything more to add before I sign out?
Just to reiterate that menopause hormone therapy is first-line treatment for the severe symptoms, but don't feel like you're missing out if you're not taking hormones, okay? See your doctor, discuss it, just have the full discussion, have all your options laid out, and be free to pick a choice based on your values and your preferences and what you want.
And we're about giving women options.
Yes.
Yeah. And absolutely. Educating and informing them about what options they have. Yeah. And that's what empowers us, right?
Yeah.
All right, then. All right. Have a good one. Thanks for signing in, and bye.